Hi, everyone. I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies. And today we're continuing our series, what I'm calling From the Vault. These are podcasts from the past that I think are really important. I want to dust off and reproduce so that you can hear them, because I know it's not so easy to go back, a couple years and see what we have back there in our past podcasts episodes. So here it is. These are some of my favorite. So this one is called How to Overcome Traumatic Childbirth Experiences with Dr. Rebecca Dekker. The reason I wanted to bring this one back is because of a really startling, upsetting statistic. 1 in 3 parents that have given birth perceive that birth experience as traumatic. That is a staggering, upsetting number. At PYC, we really try to do as much as we can to support new parents, recognizing there's only so much that we can do. We try to go through the yoga postures, create balance in the body, try to be mentally and physically prepared, educationally prepared, but there's more work to be done. And that is why I wanted to reach out to Dr. Dekker. So in this conversation, we talk about how would you define a traumatic birth? What are some of the biggest factors that play a role resulting in a traumatic experience? What are some red flags that you might notice that may indicate you want to switch to a different care provider? We also talk about how parents can help advocate for themselves and what they can do if they're feeling pressured or coerced by their care provider. We really dive deep into this conversation so that you can feel that your birth ahead of you can be more of a positive experience, because I don't want you to be one of the 3. And if you are, Rebecca talks about how to help overcome that. Let me tell you a little bit about Rebecca Dekker. She is a nurse with her PhD and is the founder and CEO of Evidence-Based Births. She's the author of Babies Are Not Pizzas, They're Born, Not Delivered. Previously, Dr. Dekker was an assistant professor of nursing at the University of Kentucky. In 2026, she shifted gears to focus full-time on the mission of evidence-based birth. Dr. Dekker is also the host of the podcast Evidence-Based Birth. She has so much knowledge, and I'm so excited for you to hear that. Before we get to my conversation with Dr. Dekker, I always love to give you updates about what's happening at Prenatal Yoga Center. So for our latest schedule on our in-studio, our online and on-demand yoga classes, you can check that out on our website, prenatalyogacenter.com, as well as all of our workshops. We have childbirth education, lactation prep, newborn care, infant safety CPR. We have all that on the website. It is so important to me that you feel ready and supported so that we have all of our in-person workshops also available on demand, because I know not everyone's on the Upper West Side of New York City, and I still want you to have that information and support. I also know that we have a lot of yoga teachers that listen to this podcast and follow us at Prenatal Yoga Center. And for those that love what we do and want to become part of it, we have a teacher training, a PYC method teacher training. 3 times a year we offer it online, and once a year we offer it in person. So if you are passionate about supporting the perinatal community and you want to know our specific methodology, check out our website. You can learn all about that. All right, I think that is it. Let me just say thank you for listening. Thank you for your reviews, and thank you for always reaching out and sharing ideas and guests with me. All right, we're going to take a super quick break, and when we come back, please enjoy my conversation with Dr. Rebecca Dekker. Hi, Rebecca. How are you?
I'm good. Thank you so much for having me back on the podcast.
I know, I'm really excited because as we figured out the years, I think the first time I spoke to you was 2016. So it's been a minute, but I'm really excited.
Almost a decade.
I know, which is bonkers. So let's jump in, because I know we're going to talk about overcoming traumatic childbirth experiences, which is a lot. But I guess before we get into that, can you just tell me a little bit about yourself and what initially inspired you to be a nurse and then a researcher and then totally shifting gears to evidence-based birth?
Sure. So my mom is a nurse, and I got the opportunity when I was growing up to do some volunteer nursing work with her, shadowing her. And I saw firsthand actually particularly in how she helped pregnant women and teenagers and their babies, and how just a little bit of nursing education and knowledge could be life-saving. And so that was what inspired me to shift gears. I originally wanted to be a veterinarian, and I switched to wanting to be a nurse. And so I went to nursing school, and then I was inspired to become a nursing educator because education has always been something that I love doing. So I got my master's and then my doctorate with the goal of being a nursing professor. And so for many years, all through graduate school, and then for 6 years afterwards, I was teaching nursing students and doing research, because a PhD in nursing is a very research heavy degree where you're learning all about how to critique studies and to do clinical trials, enroll patients, analyze the data, publish papers, and that sort of thing. So I thought that was going to be my life. But then I had my first baby and then my second, and the two experiences were so different. The first was, I would call it somewhat traumatic. And then the second one was the opposite. It was completely empowering. And that inspired me to shift my research interest into birth, because before that, although I had been collecting the research on different childbirth practices for my own personal use, I had actually been in a different field entirely of cardiovascular nursing. And I decided to shift research interests. And as part of researching birth, I decided to start a blog just so I could kind of post my findings as I went. And I invited people to come on that journey with me. And before I knew it, within a couple of months, there were just like thousands, and then tens of thousands, and then hundreds of thousands of people, waiting to see what I would write. And it was a really fascinating journey that we all went on together.
I was one of those people. I watched your blog grow because I've been in this field for over 2 decades. And I remember when you came on the scene, it was exciting. I know that sounds really geeky, but it was exciting because it's right there in the title. It was evidence-based. And I felt I could rely on what I was reading because I knew that you did the research. And I found that really exciting because it felt like I really understood. I didn't have to do the research. Like you did it right there. And the writing was so understandable to a layperson who didn't have the background of reading study after study and deciphering the information. So I remember it coming up, and I still go back to it many times if I'm looking something up. And if you pop up on my search, I'm like, oh, this is where I'm going to go. So I guess for those, I'm talking about your website and even your podcast, and some people may not know about it. So can you just briefly describe evidence-based birth?
Mm-hmm. So at Evidence-Based Birth, we have a team of about 12 people, and there are 3 of us who focus on research. And we gather, collect, interpret, kind of analyze, and then write out in regular people terms the results of the research. And then we make that publicly accessible on our website. So if you go to evidencebasedbirth.com and then you go to our signature articles, that's where we post all of our peer-reviewed papers that are written for parents and professionals. And it's a really cool way of leveling the playing field so that you can come to your appointments with the same info that your provider should technically know, although they don't always know it. Similarly, a provider can show up at a prenatal visit and have these kinds of handouts and this information at their fingertips. So it kind of makes everybody's job easier. And so it started as a blog, shifted into a podcast, so the Evidence-Based Birth podcast. We also have a YouTube channel where all our podcasts are posted, as well as other videos, childbirth class, and then we do continuing ed for birth workers. So we're entirely self-funded. So we don't take any income from advertisers or sponsors. And we just fund through people who support our work, who want to support what we're doing. And so they take our classes online.
It's great. It really, and I love that people can then have better communication with their care providers, which is what I'm going to use that as a segue to start talking about care providers. So let's start to talk about overcoming traumatic childbirth experiences, which we're hoping, though, people are going to avoid that. So I guess let's start with, how likely is it for someone to emerge from birth feeling like they had a traumatic experience?
Yeah, so it's more common than you would think. So birth trauma is defined as a birth event where there's actual or threatened serious injury or death, or if while you're giving birth, you feel like you were stripped of your dignity or treated inhumanely. And so it's estimated to happen in about 33% to 45% of all births in the United States. And this is one reason it's so common. If you go to a baby shower, people start sharing their birth stories, and about half the time they're pretty traumatic. It's almost like everybody's sharing these horror stories. And the sad thing is that, it's not just about medical complications. Sometimes it is, and that's what causes the trauma. But more often than not, it's because you experienced cold, unsupportive, inhumane treatment, or you were degraded or made to feel like a piece of meat or like you didn't matter. Or your care providers, maybe they didn't communicate with you. They talked over you like you weren't there and there was a medical emergency happening. And so you take that medical emergency and you combine it with the fact that nobody's talking to you. Or you may experience coercion or pressure or fear tactics used on you, being told that you have to comply to keep your baby safe. And then it makes you feel like your baby's life is in danger. And then the other weird thing about birth trauma is after it's over, your experience is almost never validated. Everybody tells you, but you have a healthy baby, or but you ended up with a vaginal birth, or you walked away with a baby, which is also in a way not a nice thing to say to somebody, because some people don't, So I was fortunate in that I didn't have any major psychological ramifications from the traumatic experience that I had, which mainly had to do with the fact at a vacuum assisted delivery, after which they took my baby away for 3 hours for no good reason. And that separation was the traumatic part for me. But some people will go on to develop PTSD, and not everybody does. You're more likely to have PTSD if you have a prior history of anxiety, depression, or trauma, or if you experience a medical complication such as a postpartum hemorrhage, or if you're a survivor or victim of sexual assault. So those are the kinds of people that are at even higher risk of having PTSD after birth trauma.
When I was attending births as a doula, I saw a lot of what you just said. I remember there was one care provider in particular. She would talk to me instead of my client, the person actually birthing, and I would try to shift the focus. And I don't know why she was talking to me, the doula, instead of my client, the one birthing. And then I had seen that scare tactic of this is for if you don't do this, something could happen to your baby. And no parent is going to, everyone's going to listen to that. And it is traumatic. I've also seen partners get traumatized from how their partner was treated. It's more prevalent. I'm glad that you shared those numbers, because it's a lot more prevalent. And when we think about how common a C-section is, about a third of people, you were saying, was it 35 to 45% of people? That's an enormous number. So when we compare that, it's just, wow, it's mind-blowing. So what are some of the biggest factors that play a role resulting in a traumatic experience?
So I think, what I mentioned earlier, it's in the definition itself. So it's the either experiencing some kind of life-threatening or potentially life-threatening illness or injury, but also the whole being treated inhumanely. So I would say a lot of birth trauma is preventable, because you can't always prevent medical complications, but you can control how people care for you during those complications.
Well,
and unfortunately, so we don't have trauma-informed care in most of our healthcare settings for labor and delivery. There are nurses out there and midwives who are working really hard on trying to get the message out about trauma-informed nursing care and trauma-informed medical care, but it's still, I would say, is the exception rather than the rule.
So let's talk about, I think what I'm hearing you say is the provider plays a huge role in someone having a traumatic birth. So what are some of the red flags that someone may want to be on the lookout for, that their provider may not be the best fit for them and inadvertently create a traumatic experience?
So I can tell you one of the first ones that comes to mind is something that most people don't think of, and that is continuity of care. So are you familiar with what that means, Deb?
Yes.
Okay. So if you're listeners who don't, it means that there is a person attending your birth who is someone who is known to you and you trust them. And we can talk all day about red flags of providers, but if you don't know who's going to be there at your birth, how can you test for red flags? Right?
And especially in New York, where most of my listeners are, they have these huge practices, anywhere from like 4 to 12 people. And while they may see them once in a rotation, it's very up in the air of who's going to actually be there.
Yeah. And it's a hard lifestyle for those providers who do choose to provide continuity of care. They're more typically midwives, but not always. But that means that you have to go to every single one of the births, that you're on call all the time, essentially, which is a very difficult life to live, as doulas and home birth midwives know. So continuity of care is important. It's not always practical. But the problem is, if you get into a really large practice, like you mentioned with 12 providers, you might be able to meet a few of them, maybe even 5, but then there's still like a more than 50% chance that someone who's at your birth is unknown to you. And so it's a potential red flag if you cannot get to know the other providers in your practice. In that case, then I would really rely heavily on doulas in your community. So my guess would be that there are probably some highly experienced doulas in New York City who could tell you about the different practices and be like, this practice has all great providers, like you can't go wrong. This practice has several providers that you need to watch out for. And doulas are usually the ones who know this info because doulas see so many different births and so many different providers, even more than nurses might, because nurses might only see providers from specific practices, whereas doulas are going, to many different hospitals. So that's something to just be aware of. We can talk about red flags, but knowing who is your provider is part of it. But other red flags, including if their hands on the doorknob as you start to ask a question. So just any sign that they are not listening to you. Because if they're not listening to you in a prenatal visit, they probably won't listen to you in labor. And, any fear tactics where they immediately, instead of giving you information, their first reaction is to always give you fearful information or fear-based information, such as immediately saying, hey, let's go ahead and schedule your cesarean just to get it on the books.
And I hear that or an induction. Let's just get your 39 weeks just scheduled, just so we have it on the books.
Yeah,
so you have your
no
spot.
Informed consent discussion. It's their way or the highway, or they're just kind of assuming that you're going to go along with them. That is a red flag. Body language, crossing their arms, rolling their eyes at you, which should never happen, but that would be huge red flag. Anything that makes you feel dismissed, that they don't have time to listen to your concerns. And those are, I think, the major ones, but also just finding out, what are the birth workers in your community say? Like, what is the word on the street about those providers? And that can be really important.
Yeah, these are really, really great, because I think that what sometimes happens is somebody is with a care provider while they're pregnant, and then before they're pregnant, and then they find out they're pregnant and they just keep chugging along. And then I see this happen all the time. And then they get further into their pregnancy, they get educated, they get excited. And then when they approach conversation, they start to realize, oof, I might not be aligned. And then they often end up sticking with that care provider and hiring a doula, hoping that would help. But it's a bit of an uphill battle if they're really misaligned from the beginning.
Exactly.
Yeah. All right. So what are your 3 top tips for preparing for childbirth or reducing anxiety about childbirth?
So I know a lot of your listeners love yoga, or maybe yoga instructors, and have done prenatal yoga. And I just want to give a shout out to prenatal yoga as the entry into, for many people, learning evidence-based information about birth. And I know for me, I don't talk about this enough, but that was a big part of my journey, is sitting in a prenatal yoga classroom with our instructor, Ann Rust, and she would hold space for us. And she was also a doula, and she knew all the problems in our community, but she didn't use fear tactics. It was a safe space. And she introduced things to us that I did not take her seriously enough the first time. So she was the one explaining what a doula is and how beneficial they can be. She was talking about the importance of childbirth education and movement and getting to know your body and practicing different movement. And I hate to say it, but I did not listen to her advice about hiring a doula, and I did not
I love your honesty.
Yeah. I just wasn't ready to hear it. And you know what? Also, my partner didn't want a doula, because this was 15 years ago and doulas were very still much on the fringe. Not many people knew what they were, which is different than today. Most people will know what a doula is if you just ask random people in their teens, 20s, or 30s. They all seem to know what a doula is. And he didn't want a stranger at our birth. And that made me, think, I guess you're right. But then it wasn't until afterwards that I realized there were so many strangers in our room anyways, that was a really silly mental block to having a support person there. So definitely hiring a doula is one of the top 3 tips. Doulas have been shown in the research to lower anxiety, to lower pain, and to help you have a less complicated, healthier birth. So out of all the things that you can do, that seems like one of the most important if you can. And fortunately, we have a lot more ways of accessing doula support than we used to. A lot more grants and funding and nonprofits that did not used to be available. It used to just be, you had to shell out a certain amount of money, and that was the only way you could do it. Mm-hmm. The second thing preparing is really educating yourself. And I prefer education where you're getting mentorship from someone who's not an employee of the hospital, but that's my personal preference. Mm-hmm. I know there are some good hospital-based birthing classes, but I have found you get an independent perspective can be helpful. Mm-hmm. Someone who is understands the different hospitals and how they practice.
Yeah, and they're not just kind of guiding you through the protocols of that specific hospital. You get a little bit of, like you said, a broader sense of all the options instead of just the option that the hospital may want you to follow.
Yeah, and research has shown that independently run childbirth classes give you that information. Whereas in the hospital, there's immediately a conflict of interest because they don't want to tell you about their statistics or, ways to get around their policies because they're trying to get people to not rock the boat. They want you to be educated, but not too educated, if that makes any sense. So yeah. I think childbirth education has also been shown to lower anxiety, help you feel more prepared and confident. And for some people, I don't know if you've seen this, Deb, but some people approach anxiety in like one of 2 ways. Either they're anxious about something, so they have an avoidant response and they avoid everything. Or they are anxious, and so they gather as much information as they can. Mm-hmm. And although people who avoid information, they could theoretically still go on to have an empowering birth. I think if you're carrying that much anxiety and then you don't learn anything, it just makes the whole birth experience terrifying. Whereas if you are able to confront those fears in pregnancy, get educated, get information that makes you feel more powerful and more in control, then that can also go a long way to empowering your birth experience.
I think a lot of our students fall on that second one, that they are just hungry for and very motivated. I was to get as much information as possible. And then I think they feel more capable of having a conversation and I don't want to say holding their ground, that sounds confrontational, but to actively participate in the decision-making because they have a foundation to speak to the care provider from.
Right. They do. And the information is important too, I think, and finding the right fit for the kind of information, you need. I remember I was, again, going back to my first pregnancy, I can picture myself in that prenatal yoga room. And there was this sign on the wall for hypnobabies. And I just thought that was ridiculous. I was like, that is so silly. And then look at me now. I've had 2 births using hypnobabies, and they were extremely empowering. And for someone like me who had a lot of anxiety about my birth after my first traumatic birth experience, it was really important for me to do that the second time, to learn the strategies for like centering myself and lessening my anxiety, which self-hypnosis programs are really focused on.
Mm-hmm.
So that was a good fit for me. So it's about finding the class that's the right fit for you. The EBB childbirth class, on the other hand, is more about like the information and the tools and the physical and some mental tools. But every class has a different kind of angle, and then every instructor is different. There are some instructors who are great fits for example, VBAC, or if you are planning a cesarean, someone who can help you learn how to have a family-centered cesarean. So finding a great childbirth educator is another important option. And then the third thing is having a great relationship with your provider. So we talked about red flags, but you can imagine walking into the birth, if you know and trust your provider and their colleagues, how much calmer you would feel. And it is so hard.
Can I jump in and ask a question?
Yeah.
If most appointments are so quick, how does somebody, because I've heard this from so many students, I had like the unicorn OB, and I also had a midwife. He would give me so much time, which is why his appointments always ran so late. And then I also had a midwife. But most care providers, they're so in and out. How do you recommend getting that relationship when I think the average appointment is like 7 minutes that you're actually seeing your care provider?
Yeah, this is something that we practice with our childbirth class students, is how to get the most out of a prenatal appointment. So, of course, this is the difference between what we call the midwifery model of care and the medical model of care. The medical model of care is known for its very short appointments, very little time for education, questions, nutrition, counseling, that sort of thing. It's kind of focused on the physical aspects of pregnancy, but not the social support, emotional support, or preparation for birth. Whereas the midwifery model of care tends to have, not always, but tends to have longer prenatal appointments with more time to talk about your concerns and your questions and to get to know your provider. And I believe this is one reason that the randomized trials on midwifery models of care have found lower preterm birth rates and lower miscarriage and stillbirth rates with midwifery care.
Oh, that's so interesting.
Yeah, because of, I think it's multiple things, but that trusting relationship where they care about you holistically and get to support you socially, emotionally, psychologically. And then also they're doing nutrition counseling and things like that. So if you're really disturbed by the fact that your prenatal visits are 5 to 7 minutes long, that's something to think about. Is it an option for me to switch to midwifery care? It may or may not be an option. That's something to think about. The other thing is to practice asking questions at your prenatal appointments. So what I recommend doing, especially if you don't feel comfortable using your voice or you feel rushed at your appointments, is to bring a sticky note with you that has written down 2, preferably 3 brief questions you can ask your provider so that you get in the habit of asking questions early and often, and that they then expect that from you.
Oh, I love that.
Yeah. So definitely encourage that. And then you have that in your hand. So you can't walk away, or if they're starting to walk away, you can say, oh, I have these questions. And it's just on a little sticky note. So it's not overwhelming to them. But that's where it starts. And then you can see how they respond to your questions.
Yeah, and then make a decision like, is this the person that's going to support me? My midwife would schedule 45-minute appointments. It was long. I liked it, but it was definitely long. Okay, we're going to take a quick break. And when we come back, let's actually talk a little bit about labor induction and if you want to schedule one. All right, we're going to take a quick break. We'll be right back. All right, we are back. All right. So I know that this is something you've talked a lot about on evidence-based birth. So let's talk about what is your expert's take on what to know before you schedule an elective labor induction?
Sure. So I think, first of all, I want to acknowledge that people have been trying to start labor for thousands of years, probably longer. There are ancient methods that have been written about or illustrated, and it's not a new thing. But what is new is the number of care providers who are either recommending or pressuring people into an elective induction, which means you are starting labor before contractions have started on their own, and that there's no obvious medical reason for the induction. You don't have a complication that they're trying to manage. So a lot of the elective induction rates have been rising around the world, but in the US in particular, there was a clearly documented jump or increase in induction rates at 39 weeks after a specific randomized trial was published in 2018.
The ARRIVE trial, right?
Yeah, called the ARRIVE trial. So this was, it took place at 41 hospitals in the US, and they randomly assigned about 6,000 people to either an elective induction at 39 weeks or waiting for labor to start on its own, which would possibly end in an induction if an induction was needed or wanted or you reached 41 weeks. This was the largest study ever on this topic. And they mainly did the study to see if it was better for babies. That tends to be a common theme with this research. They're not so much concerned about your experience as, the baby's health. And they actually found no difference in the primary outcome of death or serious complications for babies. But they did see a slight reduction in the cesarean rate. It was 19% in the elective induction group versus 22% in the expectant management group or the waiting group. There's also a lower chance of developing high blood pressure if you were induced early, 9% versus 14%. So as you can see, these study results were not conclusive. They did not show the world, hey, this is the best thing in the world. Let's start doing it. Another reason you wouldn't apply these results to everyone is these were people who are not seeking midwifery care. They probably weren't interested in a natural birth or unmedicated birth, if any of your listeners are interested in that. And just inducing someone to lower the risk of cesarean by 3 percentage points is a pretty invasive, expensive intervention. And I think people who are listening should know the take-home point is that if you want to be induced a week before your due date, there's really no reason why you shouldn't be allowed to. So it's a decent option, but you have to know the drawbacks. And the drawbacks include the fact that inductions are invasive. And for a first-time birthing person, they can last 2 to 3 days and nights. So that's a really big commitment. And if you're being pressured into it, but then not being told about all the interventions that it entails and the fact that it's long and exhausting and painful, even with an epidural, it can still be painful because of the different procedures they have to do to get your cervix ready. So those are kind of that's the bottom line on the 39-week inductions.
I actually really appreciate you laying it out because it has become very common to hear, oh, my doctor recommended 39 weeks, so of course I'm going to do it. And there's usually, it's just accepted. And I like that you're saying, if you want it, absolutely, but know the big picture behind it, know the risk versus the benefits so they can make an informed choice.
Mm-hmm. For sure.
All right. So I know another thing that comes up when we were talking a lot about care providers, and one thing that can make somebody feel seen and heard is realizing they may have a different birthing position than they want. I remember, super quick story, when I was a brand new doula, it was the third birth I ever attended. So brand new. My client was pushing, she was like my height, like 5'2", a small person, and she was pushing on all fours. Her main doctor was not there yet, but there was a resident. I still remember this resident. And my client was pushing and said, okay, it's time for you to deliver that baby. Get on your back or flip over. I think the words were flip over. And my client's like, no, she kind of pleaded. And the doctor actually said, I'm not going to deliver you until you're on your back. I was so new. I did not know how to advocate better. And she went on her back and she pushed out of spite. She pushed a 10-pound. This was a big baby. She tore. It was awful on so many levels, but it was like a power play and I'm sure ended up being traumatic. So what's a way to have a conversation with a care provider about alternative birthing positions and their benefits and feeling like it can be a conversation, not that they have to follow what the care provider says?
Wow. That's a really sad
It was
story.
awful.
Yeah, it makes me sad for you and your client.
Yeah.
I think you're right that it does come down to a power play in some situations. In some, and others, it just might be a fear issue. One of the things that I've learned in looking at the research and just being involved in birth in the last 12 years is that many providers have never seen an upright birth. They've only ever seen birth with someone on their back. And so to them, there's so much risk involved in obstetrics. Like it's, the highest risk profession for malpractice. And even if you have insurance, which is super expensive, just going to trial is a traumatic experience for an obstetrician.
Of course, yeah.
So they see an upright birthing position and they think it's backwards or upside down in their mind because they've only ever seen a baby coming out with the birthing person on their back.
Mm-hmm.
So all of the landmarks on the baby's head are like flipped. And so they feel like they can't see when there's a complication happening because they're not familiar with it.
Got it.
And so they think, well, I can't handle a complication. Like if I need to do some maneuvers because there's shoulder dystocia, I don't know what to do. Even though they don't realize that shoulder dystocia is less likely in an upright position. Upright positions are so helpful because they work with gravity. They help open your pelvis more. It provides more oxygen to the baby because you're not compressing your aorta. It's less painful to birth in an upright position. You're less likely to need an emergency cesarean, and you have a much more positive birth experience. But around the world, we still see healthcare workers coercing, pressuring, or even forcing people into non-upright positions, either because it's more convenient or it's power play like you saw, or they just are afraid of the upright positions. And because of that, it's still quite uncommon to see upright birthing positions. And even though research evidence, there's just like stacks and stacks of studies that support either upright or side lying positions. And when I say upright, I mean squatting, standing, kneeling, hands and knees, or using a birth stool or birthing in the water, which allows you to be upright. And with epidurals, you tend to see more side lying positions, but that is also beneficial. And it's hard to know how to handle that when a provider insists that someone gets on their back. But then this is again where I'm a strong believer in training people in advocacy techniques in childbirth education. So in the EBB childbirth class, we actually rehearse what you would say to a provider if they insisted you get on your back and you didn't want to.
Because I definitely want to talk to you later about advocacy. So can I drop into that now? So like, what would be a way, like what would a conversation or like a prompt be so that they can talk to the care provider?
So in my belief, it is the support person, whoever your birth partner or companion is their job to speak up for you. So we always do this as a group. It's all about empowering the unit that's birthing together. So what I would, as a childbirth educator, is I would say, all right, let's practice. You've told, your birth plan says you want to birth in the position of your choice, and your provider knows this. But then they say, I need you to get on your back. You can push in an upright position, but I need you to get on your back. First of all, that's something you need to figure out before in a prenatal visit. So when you talk about upright birthing positions on your birth plan, you need to clarify with your provider that they are okay with you pushing and delivering in an upright position. Because a lot of, excuse me, a lot of providers will say that they're comfortable, but they don't clarify with you that you still have to deliver on your back. So I think covering that in a prenatal visit, and then if there is still an issue, if the provider said, I need you to get on your back, before I can deliver this baby, the partner could say something like, is that necessary? And if the provider says yes, they could say, well, can you tell me more? Why? Well, I need to be able to handle an emergency if it occurred. And then you could say, is there an emergency happening right now? They could say no. And then you could say, hey, honey, the doctor wants you to get on your back. Do you want to stay where you are, or do you want to get on your back? And then the patient would say, I want to stay where I am. And then the partner could say, she said no, she's going to stay like this.
I love that.
So that's an example of something we would rehearse. But I love the she said no or they said no line, because you're just amplifying. You take what the doctor's saying, you translate it to them. I mean, if it's clear it's not an emergency, then there's no reason, then the person can do what they want to do. And you just echo what they say to the doctor. It's that easy. She said no. She's going to stay on her, hands and knees for now.
What a really empowering way to advocate without being confrontational, because I know that's something people are concerned about, and not feeling like they're being pressured or coerced, and kind of neutralizing the situation if it's starting to feel a little bit like it's ramping up.
And
I love that.
Yeah, so frustrating though. I know you have a lot of yoga instructors, and I remember so much of our yoga class when I was pregnant each time was practicing positions that we wanted to push and birth in. And how disempowering then to be told or pressured to get on your back when you didn't want that. Now, if you want to switch because you think it'll be more comfortable, then that's one thing. But if you're being pressured into it, it can be so disempowering. So it reminds me of so much of birth and advocacy is just about setting boundaries.
Mm-hmm.
And I think especially people who are socialized as women and girls, we are taught to people please and to, never say no to an authority figure and to not make enemies. And there's a lot of gut instinct when you're pregnant to not rock the boat. Mm-hmm. But if you just think of it as a boundary, this is my boundary. I have the human right to birth in the position of my choice. And you stay firm in that right. And the people you brought with you to the room also know your wishes and your rights, and they can just reaffirm your rights.
Yeah, we actually talk a lot about that in our classes about making choices. We try to make our language and our offerings very invitational so that people can make choices about what's best for them. Because my thought is, if they can start to exercise that muscle on the yoga mat where the stakes are pretty low, you don't like something, right, you don't do it. So if they can exercise that muscle there, it can feel like, oh, I can go not against, but I can handle bigger situations where I'm holding my bounds and I'm making choices.
Yeah,
so
and then
it's
making sure it's not just you, though, that you have a support person there who is ready to stick up for you, and know that the World Health Organization says this is like a huge issue, that women should be supported in birthing in the position of their choice. And so it's considered obstetric violence to be forced or pressured into a position you don't want to be in when you give birth.
Yeah, I love when I'll have my students, I'll say, well, ACOG said this. And that way I feel like they're then talking to their care provider, kind of like, we're on the same team. So why are we not really seeing it the same way? I'm really enjoying this. All right, we're going to take one more break. When we come back, what is one final tip or piece of advice you would like to offer new and expectant parents? We will be right back. So what is one final tip or piece of advice you would like to offer new and expectant parents? You have so much to draw from. I'm so curious.
I know, that's a really hard question, actually.
You're a parent, you're a researcher.
3 tips or 4, but one is, so talking to people who maybe are pregnant right now or planning on having a baby in the future, and you're thinking, oh no, these red flags were really concerning to me. I don't know if my provider is going to support what my choices are. And I would just say, if you're not pregnant yet, then you have plenty of time to do some research and find the best person for you to be your provider. And if you are pregnant, there's always time to educate yourself and build a supportive team. I have a friend who switched providers and hospitals on her second to last day of pregnancy, and she was 42 weeks pregnant.
Amazing.
Yeah. And I have known other people who fired their provider during labor. So it is never too late. It may feel like a trap, but you can be creative. You can be resourceful. You can find a way to get people you can trust at your birth. And if for some reason you feel like it's not possible, then just make sure you have strong advocates in the room with you. Have a doula, be educated, make sure your partner is ready to speak up on your behalf. And
Can I ask a follow-up to that?
Yeah.
So if someone's hearing this and they're like, yes, I want to be empowered, and they're like head to head with their care provider and they want to fire them on the spot, what happens? Who then steps in?
I mean, usually there's more than one provider at a hospital. I guess if you're in a small rural area. So in our class, I call this last resort advocacy. Okay. So this is kind of like,
yeah, it's like, it's the Hail Mary. It's your
well, and it's really bad, right? They're verbally abusive, or they are ignoring your wishes, or they're being, some other way making you feel
causing trauma.
Safe. Yeah. You can't birth safely if you don't feel safe. So if somebody is making you feel like you're in danger, or you're at risk, you can't have a safe birth experience with them, then what I would do is have the partner, and I give them all these scripts in our class, find the nurse and say, we no longer are going to work with Dr. So-and-so. He or she is no longer allowed in our room.
Oh, wow.
And then it's up to them. It's their problem now. It's not your fault that they're abusing you. Right. You don't need to, it's not your job to go find another doctor to replace them. But most of the time there's somebody else who can come in. And most of the time they come in really willing to help. Feeling bad that you've had a bad experience. And the same can be said for nurses. Not every nurse is the right fit for every patient. And you can also have language like where you go to the nurse's station, ask for the charge nurse, and just say, I don't think it's the right fit between us and our nurse. Could you please find us another nurse?
That's great advice too.
Yeah. So just remember, and those are very last resort.
Right.
I rarely see that happen, but just know that, again, it's your birth, your baby, and you're the paying customer. So you got to take that feeling of empowerment and bring it to your birth. And education helps with that. Having a strong team supporting you helps with that. And hopefully this is something that you don't have to do. Your partner or your labor support companion, whoever they are, could help with this.
Really good advice. And I'm sure people are going to feel more empowered. Where can people find your work?
So you can find the Evidence-Based Birth podcast on any platform and on YouTube. And then go to evidencebased.birth.com. There is a form on the homepage to sign up for a crash course on evidence-based care. And then you can also click on the blog to see all of our signature articles.
And I will make sure all of that's in our show notes. Rebecca, it was so nice reconnecting after almost a decade.
I know. Thank you so much, Deb, for having me on the podcast.
Absolutely. Thank you.
This has been an episode of Yoga, Birth, Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.